The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to the Children's Cardiomyopathy Foundation's webinar on developments in research and treatment in pediatric cardiomyopathy. We're glad that you're joining us this evening. And before I turn the presentation over to our guest presenter, Dr. Towbin, we just have a few housekeeping notes. If at any point during the presentation you need technical assistance, just type in your concern into the chat window or the question box, which is on your control panel on the right-hand side of your screen. If you have audio issues and you're unable to hear properly, you can either use your computer speakers or you can also dial in from a telephone number provided by GoToWebinar. In order to provide a high-quality session today and avoid background noises, all attendees are in listen-only mode and are muted. Your questions are encouraged and welcome during the presentation. You can submit your questions via the question box, which is on your control panel, and we'll be taking questions during the last 10 or 15 minutes of the presentation. You can submit your questions as you think of them, and then we'll address them all at the conclusion of Dr. Towbin's talk. We're also recording this webinar and posting it on our online community, CCF Connect, so you can access the information at a later time as well. As a reminder, this is the second installment of this presentation. We had the beginning of the presentation back in September, and that is recorded, and that talk was focused on dilated cardiomyopathy, so you can always refer back to our recording of that session on our CCF Connect community. So tonight we're going to pick up on the hypertrophic cardiomyopathy section of the talk. And now I would like to introduce our presenter. Dr. Jeffrey Towbin is co-director of the Heart Institute at the Bonheur Children's Hospital, chief of cardiology at St. Jude's Children's Research Hospital, and professor and chief of pediatric cardiology at the University of Tennessee Health Sciences Center. From 2003 to 2009, he served as chief of cardiology at Texas Children's Hospital and as co-director of the Heart Institute and chief of cardiology at Cincinnati Children's Hospital Medical Center from 2009 to 2015. Clinically, Dr. Towbin has focused on cardiomyopathy and heart failure, cardiac transplantation, and cardiovascular genetics as his areas of expertise for his entire career. He has trained many of the leaders in the field, and Dr. Towbin's research has focused on the genetics and mechanisms of cardiomyopathy in advanced heart failure, arrhythmias, as well as inflammatory heart disease and their etiologies. His research has been funded continuously since 1987, and he has trained more than 50 postdoctoral and 20 predoctoral students, many of whom now have high-level academic faculty positions. His laboratory research team has been a leader for many years in the field of gene discovery and mechanisms of these disorders, as well as viral causes of inflammatory heart disease, including transplant rejection and transplant coronary disease. He has co-authored more than 500 publications in high-impact journals, served as principal mentor and multiple K grant-funded trainees, and has been a member of multiple T32 training grants. In 2007, he received the American College of Cardiology Distinguished Scientist Award, and in 2013 he was awarded the American Heart Association's Basic Research Prize. Thank you so much for joining us again, Dr. Towbin, and welcome.
Thanks very much, Gina. Appreciate it. Hello, everybody. For the next 45 minutes or so, we're going to talk about some of the pediatric cardiomyopathies. As Gina mentioned, we've previously, in the first installment, talked about dilated cardiomyopathy, a problem of the left ventricle not squeezing very well and getting too big, hence the term dilated cardiomyopathy, heart muscle disease. Today we're going to start with talking about more or less the opposite type of cardiomyopathy, hypertrophic cardiomyopathy. And hypertrophic, that word means thick. Cardio is heart, myopathy is muscle disease, and so we're talking about a thick heart muscle disease. And so unlike the dilated cardiomyopathy, the walls are thick instead of thin. The muscle squeeze actually squeezes better than normal, but it has a problem relaxing. So this is a problem of relaxation The squeezing part of the system, we call that systole. And so dilated cardiomyopathy is a systolic dysfunction problem, whereas hypertrophic cardiomyopathy is a relaxation problem. So this is a diastolic dysfunction problem. So the picture here, looking at the heart standing upright, where you have the head at the top, the feet at the bottom. And so right in the middle, you see this very thick wall between the two other side walls, and you see the LV stands for left ventricle. That left ventricle is very small, and it's very small because the walls around it are so thick. The side wall and the middle wall are the septum. If this was in motion, what you would see is that the side wall and the septum actually come so close to each other when it squeezes that they almost kiss, and therefore the blood below it would be obstructed from going out to the body through the aorta. So that becomes the problem associated with hypertrophic cardiomyopathy. So the disease is characterized by thickening of the walls of the heart, with the interventricular septum, the wall between the two ventricles, being typically the thickest wall. We call that asymmetric septal hypertrophy. The heart usually squeezes better than normal, so it's hypercontractile systolic function, but it has a relaxation problem and appears to be very stiff when it relaxes. In other words, doesn't relax very well. And when I see patients in person, what I usually try to describe is, if you see a muscle builder like Arnold Schwarzenegger in his prime, people with these huge muscles from all their working out, what you notice is that when they walk around, you see that their arms really never get straight by their sides. And that's because they have such big muscles that are so stiff that they actually can't straighten their arms out. And that's a similar problem here. The walls are thick, just like the muscles are in a muscle builder, and they don't relax very well. And so that's the underlying problem associated with what I'll call HCM the rest of the way. The annual incidence of this in childhood is about 4.7 per million children. So for a cardiomyopathy, it is one of the two most common forms of heart muscle disease. We see it more in boys than in girls, 5.9 per million versus 3.4 per million. And we see it most in children less than a year of age by quite a lot. And typically there's a second bump in uptick in numbers at around puberty and beyond. So between 1 year and about 12 or 13, there's sort of a honeymoon period where you don't see very much. And at the less than a year of age and greater than 12 or 13, you see the second uptick, but it's not nearly as much as you see in the first year. The problem with this disease that's gotten it a lot of press over the years is that it's one of the leading causes of sudden death in young, healthy subjects, including high-end athletes. So Hank Gathers, a basketball player, died suddenly on the court, and he had hypertrophic cardiomyopathy. And there's many other athletes that have had the same problem over the years. And so this is really what gives it its name and its recognition as a problematic disorder. It's the sudden unexpected events. And these are typically in individuals who either have not been diagnosed or have not followed sort of the rules of the game of how you take care of these individuals. Once you're diagnosed and treated and followed properly, this should be a very, very uncommon event. So here shows different looks of the heart in hypertrophic cardiomyopathy. You see in the middle here, the septal wall is quite thick. It bulges in this left to right sort of fashion. It bulges into the left ventricle. The side wall is also thick, but not as thick as the center wall, so asymmetric septal hypertrophy. On the far left you see that the walls are about equally thick, so more concentric hypertrophy. And on the far right here, you see that the walls are equally thick, but the chamber dimension here is bigger than it should be for a thick heart. You see here the chamber is small in the middle version. And this is a hypertrophic cardiomyopathy that's starting to burn out, as we call it, starting to dilate up. The hypercontractile function starts to lessen and in fact gets to be less than normal. And then they have a combination problem of squeezing and relaxing problem, and that leads to heart failure in these individuals. And so they have to be treated in a slightly different way if they get to that point. Very uncommon outcome in pediatrics. We do occasionally see it in late teenagers, but it's an uncommon scenario in kids, more common in adults. So outcomes, if you're in that group of individuals who present the earliest, less than a year of age, and therefore the largest number of patients, they actually also have the worst outcome. And the reason for that is they tend to have a slightly different disease as far as the underlying cause than children above the age of 1 that develop this disease. These patients commonly have a more systemic problem. In other words, it's a more than just a heart problem. It can affect other organs, typically due to metabolic abnormalities. And so their outcomes are equally affected by their other parts of the system, the brain, the liver, the kidneys, that adds burden on top of the heart problem, and they can have a poorer outcome than all of the other kids. Children older than 12 years of age, so the 12 to 18 year group, or even up to 21 if you like, have a worse outcome than other kids above the age of 12, and that's all sudden death related, whereas the kids in between 1 and 12 rarely have any events. Again, that's a honeymoon period where kids do very well, almost irrespective of what their imaging looks like. Children with inborn errors of metabolism, so the kids with metabolic abnormalities, have the worst outcomes compared to any of the other kids, whereas the more standard underlying gene mutations in these genes that encode proteins called the sarcomere, which are proteins that make up the contractile apparatus of the heart. So these are the genes that older kids and adults have as the cause of their hypertrophic cardiomyopathy. They tend to do better than these other groups of patients, and they also tend to have more of the asymmetric septal hypertrophy form instead of the concentric hypertrophy form. So when you look at the imaging of these kids, as well as the history that they present with, we can define to some extent who has the highest and who has the lowest level of risk. And on this chart, what you see is from left to right, the highest risk individuals and the risky scenarios that come along with it. So the individuals who have massive left ventricular hypertrophy, these are the patients who have the thickest walls. These individuals, at least in the adult age range, have a worse outcome than individuals with less severe. And in the adult age range, we're talking about approximately 3 centimeter septums. In young kids, you can't use that number. You can only use the comparison to their size, which we call z-scores. And a z-score of 8 or 10 and above puts you into that class. Kids who present with syncope. Syncope is another term for fainting. If you presented with a fainting episode and you have hypertrophic cardiomyopathy, that's considered a life-threatening event that you were resuscitated from. Either you self-resuscitated or somebody resuscitated you. That's a high-risk scenario. If you're in a family that has known hypertrophic cardiomyopathy and or sudden cardiac death, that's another risk added to the profile. If you have non-sustained ventricular tachycardia, that's another but a lesser issue. And then if you run on a treadmill and your blood pressure normally goes up and up and up, but in your case goes up, and then when you reach approximately peak exercise, it actually starts to come down instead of continue to go up, that also adds to the risk profile. So when we put all of these things together, we can develop a risk profile and separate individuals theoretically into the higher, mid, or lower risk categories. Again, irrespective of any of these risks, the risk of sudden events is still a very small number, particularly if you're being followed and treated appropriately. And if we ask the individual to stay out of certain sports and stay away from certain medications, etc., the risk is really pretty low. From the genes perspective, this is the cardiomyopathy that has the longest history of genetics being performed on them. What I'm showing you here is that there are many, many genes that have been identified associated with hypertrophic cardiomyopathy. But the truth of the matter is that there's only 2 or 3 genes that really cause the vast majority of individuals with hypertrophic cardiomyopathy. The most common would be the beta-myosin heavy chain. Very common. It was the first gene identified and is quite common. Cardiac myosin binding protein C is the second most common, and beta-myosin heavy chain and cardiac myosin binding protein C are about equal in how common they are. And then one of the troponins, troponin T, would be the next one on the list, but much less common. You can see 25 to 40% between the beta-myosin heavy chain and myosin binding protein C. So that takes up a full 70 or 80%, whereas cardiac troponin T is only about 5%. And the remaining 15% are scattered amongst a variety of smaller potatoes, if you will, in the big picture. Now, you can have more than one gene affected in any one individual, and when you have double hits, if you will, you can have a more severe form of cardiomyopathy, and some 10 or 15% of individuals with HCM will have multiple hits in different genes or even in the same gene. So that's sort of the genetics. All of these genes can be tested by genetic testing that your doctor might send off on a panel, or what we call whole exome sequencing these days. So the genetics of this has been pretty well worked out. Now, the genes, it's important to know what they are, but at the end of the day, the problem really is at the level of the proteins that those genes make. The job of the gene is to make a protein. And the proteins that we're talking about are proteins of this contractile apparatus, the so-called sarcomere. And on the top panel here, where you see at the top the A and at the bottom the M, what you see are thick lines in green and thin lines in red on the side. And these make up the thick filaments and the thin filaments of this sarcomere. And you could think of the squeezing and relaxing of the heart muscle as if this is a gate, where you have the 2 sides of the thin filaments coming together along with the thick filaments and moving towards the center and touching together, that squeezing, and then coming back to its baseline, that's relaxing, just like a gate opening and closing. Where the Z's are located, those would be the edges of each individual sarcomere, and they are linked together side by side to create the entire heart muscle makeup itself, and they're made up of many proteins. But in the bottom panel, you see the key proteins and how they're made. So at the bottom of this panel, where you see the green thick line, that would be the thick filament. And you could see the little yellow things popping off of it, that would be the myosin heavy chain head, which is that myosin heavy chain gene that I told you is so common. You can see the myosin binding protein C, which is this thing that comes down and attaches to the beta myosin heavy chain head. The beta myosin heavy chain head requires energy source, and then it basically makes the gate open and close. So you give it energy, the gate closes, it uses the energy, the gate opens. And so that's how this works. And so you can see why this myosin heavy chain would be so important, and if you mutate it and cause a problem, why you might end up with a heart muscle problem. So that's the protein basis, or really the working basis of why you get hypertrophic cardiomyopathy. It's a problem of these particular proteins. So that's all been worked out pretty well. So this demonstrates the primary causes of hypertrophic cardiomyopathy as well as dilated cardiomyopathy in children. And you can see the ages, the era is in the 1990s. It's changed a little bit from there since then, but that data has really not been put together quite yet because it's only recently been all collected. But what you can see is the hypertrophic cardiomyopathy is in the dark colors, and you can see the percentage of cases and their underlying causes, and you can see the hypertrophic cardiomyopathy, inborn errors in metabolism, very common, along as well as the sarcomere familial isolated cardiomyopathy forms. You can see that there are syndromes associated with it, and this is primarily Noonan syndrome that's associated with hypertrophic cardiomyopathy under the malformation syndromes. Neuromuscular disorders, which you can see that it's very commonly causing dilated cardiomyopathy, less in hypertrophic cardiomyopathy. This tends to be associated with Friedreich's ataxia. And so those are the key players regarding hypertrophic cardiomyopathy. The inborn errors of metabolism, really mostly associated with babies less than a year of age. The familial isolated cardiomyopathy associated with sarcomere abnormalities are in the patients older than a year, particularly once you get into the teenage and adult years. So those are the key disorders. So as I said, HCM is a well-known cause of sudden death, but the frequency of in pediatric patients is quite low. Sudden death rate is highest in adolescents, most of the time because they either have not been diagnosed because they've been well, healthy kids, they don't have heart murmurs, they don't have complaints, they just have sudden events, or they're diagnosed, they have significant disease, they should be treated, they should be monitored as far as where activities are concerned, and they don't follow the rules, and so they end up with a problem. What I'm going to also talk about is what we call HCM with restrictive physiology, or if you will, a combination of hypertrophic cardiomyopathy and restrictive cardiomyopathy, and I'll show you a picture of that in a minute, is also a high cause of sudden cardiac death. But again, the frequency of it is relatively uncommon in pediatrics, but is higher than if you just have HCM alone. So it's worse if you have the restrictive physiology associated with it. And that's because it's a increasingly significant issue of diastolic dysfunction, or a worse relaxation problem, or in other words, a stiffer heart that doesn't relax very well and doesn't react particularly well. And so what we're talking about here is enlargement of the left atrium, demonstrated here. So here would be a normal heart, restrictive hypertrophic cardiomyopathy. And so here is the left atrium at the top here. In the middle panel, you can see the left atrium compared to the left panel, the top chamber, is way big. And in fact, it's as big or bigger than the bottom chamber, the hypertrophic LV. So when you get a big left atrium, but no regurgitation of blood from the bottom chamber to the upper chamber, so it's not a problem of too much blood in there, it's a problem of too much pressure in there. That's a high-risk scenario in comparison to the straightforward hypertrophic cardiomyopathy. And so other things need to be done in this patient population from a treatment perspective, and the risk is also, as I mentioned, a little bit higher than in hypertrophic cardiomyopathy. And then in real thick individuals with very small chamber dimensions that have severe relaxation problems, so they have the big atria, the walls of here are thick, they come and they kiss, and so you can get obstruction to blood flow going out the aorta where that arrow is located, and you get blockage of flow, and you can have an event on the basis of lack of blood flow going to your brain, and have a fainting episode, if you will. So those are the pictures associated with this particular problem. So what do we do about this? And so everyone has a slightly different take on how you do it. I'm going to give you my bias since I'm the one speaking, but suffice it to say there are a lot of ways to do this. So one of the issues in pediatrics is that kids who are outpatients, so they either have or haven't been diagnosed. If they haven't been diagnosed, but they've been sent to a cardiologist for an evaluation for one reason or another, typically these are individuals who are really completely asymptomatic. So when they're asymptomatic and they have the disease, a lot of people will not do any therapy. And so that's not uncommon. They may develop symptoms over time. They may develop overt disease during adolescence if they haven't developed it early on in life. Outpatient medical therapy, what I say here is it's MD specific, so different people have different ways of doing it. Many use no therapy. Others, including myself, will start a beta blocker, and I do it at the time of diagnosis in almost all patients, unless they have a very slow heart rate at baseline. Less commonly in the US, a calcium channel blocker will be started as first-line therapy. Typically in the US, in pediatrics, if you're going to treat, you're going to start with a beta blocker. If you need more therapy, what I do is I add a calcium channel blocker later on. Usually if the patient is severely obstructed, I'll use this to reduce the obstruction, which it works very well to do that. If you develop signs of heart failure, that would be shortness of breath, development of swelling in your lower extremities, things of symptoms like that, your abdomen is getting swollen, then we'll use some diuretics to make you urinate more. But if you're going to do that, you have to be careful because you can't take away all of the blood within the heart. If you make somebody dehydrated, they're going to get obstructed. So you have to be fairly careful when using diuretics. If there's significant obstruction to blood flow, as I mentioned, combination of beta blocker plus calcium channels is a reasonable way to go. Not everybody does that. It's the approach I tend to use. But again, everyone uses their own approach. Some people get nervous in using this combination. I've been using it together for 30 years. I've never seen a problem with it. So I'm quite comfortable using the combination. A subset of patients will have early onset arrhythmias associated with it. So the heartbeat becomes erratic, maybe very fast, maybe very slow. And this tends to be treated either with medication. And in pediatric patients, we commonly start with medicines, anti-arrhythmic agents, or they need a defibrillator implanted. We call that an ICD, implantable cardioverter defibrillator, ICD, which gets placed in some individuals. In adult patients, They use what's called primary prophylaxis, meaning if you have the diagnosis and you're quite thick or there are other risks, they'll put the ICD in irrespective of the fact that you have never had any signs or symptoms to deal with of arrhythmias or anything else. We in pediatrics tend to wait until there's either an event that's been identified or an arrhythmia that's identified before we'll put it in. The reason is that kids are growing, so they may break their leads. They're also very active, banging up against each other, playing, and they break their leads. And so a broken lead isn't going to work. It may shock them inappropriately. And so the risk-benefit ratio is different in pediatrics than in adult patients. So we're a little bit slower to move to an ICD, but you know, each patient defines themselves. But as a general statement, we use secondary prevention in pediatrics. As I say here, adult HCM specialists use ICDs much more prophylactically than we do in the pediatric age range. Another therapy that people talk about in HCM is so-called alcohol ablation. It's only used in individuals with significant obstruction or hypertrophic obstructive cardiomyopathy. You might hear people talking about HOCM. This is what HOCM means. In order to thin out the very thick septum. Basically, what you do is you squirt alcohol in a catheter that is in a specific artery within the heart that goes up against the septal wall, and 100% alcohol going into the heart muscle gives you a heart attack essentially in that area specifically. So it causes scarring of that area, which then thins out that area of the heart muscle, meaning the septum, and you get a thinner walled septum. We don't use that in pediatrics. We're not going to give a young kid a heart attack within, you know, during their age range. So this is really an adult therapy. It's a second line therapy, but it is used in adults. You'll hear people talking about it. We don't do it in pediatrics. There's a surgical option called a myectomy, which is basically shaving the thickened walls and making them thinner. Again, only used in obstructed patients with symptoms. I rarely use that because kids are rarely symptomatic, but if they're symptomatic with significant hypertrophy and significant obstruction, this is the primary way to go before thinking about any other options, even in the adult world, like alcohol ablation. Now, if you're sick and in the hospital, you'll get admitted either because you have had a syncopal episode, you've had a fainting, life-threatening event, or you have heart failure symptoms. Medical therapy is the same to a large extent as what we do in the outpatient setting. We're using medicines like beta blockers to slow the heart rate down. Slowing the heart rate gives the relaxation phase more time to be relaxed and more time to fill the heart. So you get the maximum amount of blood in that small chamber, and then it squeezes better and gives more blood to the body, the slower the heart rate within reason. And so instead of using a heart rate lowering medicine by mouth, we'll use it intravenously and then move over to an oral beta blocker once the patient's more stable. Other antiarrhythmia medications may also be needed, like amiodarone or others. If you're severely obstructed and you have symptoms, these inpatients are going to get a myectomy at that point, and that's a reasonable approach when you have significant obstruction and you have symptoms, for sure. Medical therapy is not going to fix that problem. A subset of patients with arrhythmias plus minus the syncopal episodes, you're going to get an ICD, and that's an inpatient option. And if you get the burnt out form that I talked about earlier with the associated squeezing problem or systolic dysfunction, then we switch our therapy more towards what we do in dilated cardiomyopathy, which would be medicines that lower heart rate and lower blood pressure, ACE inhibitors, ACE inhibitors like lisinopril and allopril. These are drugs that end in PRIL, plus a beta blocker, which typically is either carvedilol, also known as Coreg, or metoprolol in the systolic dysfunction patients. So a slightly different therapy when you get into systolic heart failure versus diastolic disease. So those are your therapies, whether you're an inpatient or you're an outpatient. Now, are there any other therapies new on the horizon? And the answer is there's one that has some potential excitement that people have been recently talking about, and it's a molecular-based approach that is known as genome editing. So this is where we know that the patient has a specific sarcomeric gene mutation, and that gene mutation can be targeted at a molecular level and changed from an abnormal sequence in that gene to normalizing it. And it uses this targeted correction of these abnormalities or mutations are done through something known as CRISPR-Cas targeting. And this is recently described about 4 months ago in a journal called Nature, the end of 2017, where there was a patient with a family disorder of HCM who had a single mutation or a single change within the myosin binding protein C gene in a specific place, and it was a deletion change within that particular spot in that gene. And what they did there was they took out some embryos from this individual. They took some cells, they created embryos, and they then used this CRISPR-Cas to try to target the mistake within that gene. They went ahead and did that. They were able to create eggs that turned out to fix the mutation, and about 75% of all of the eggs that were made, or the embryos that were created, turned into healthy, non-mutated cells, whereas 25% did not. But it's a proof of concept that potentially genes can be changed through this method. We're not close to be able to do that in an actual human, but this is the approach that was taken in these embryos. And so there is a defined approach that could be used where you change these abnormal changes within an embryo and turn them into normal. So whether or not that's in our future or not remains to be seen, but it has the potential to be a real change to occur. If it ever happens, it'll take some time, but the proof of concept has more than just a little bit of interest associated with it. Okay, now I'm going to switch into the other significant diastolic dysfunction disorder. I mentioned hypertrophic cardiomyopathy with restrictive physiology, or in other words, a combination of hypertrophic cardiomyopathy with restrictive cardiomyopathy. Here I'm going to just talk about what restrictive cardiomyopathy is, and then we'll go back to the combo hypertrophic restrictive to relook at that, just to put the two back into your mindset. So the genetics of this is known. These tend to be very similar genes to hypertrophic cardiomyopathy, despite the fact that they're not thick walled. They're still the same genes that cause the restrictive features, the very stiff heart. One of the troponins, troponin I, is the most common. It's not common in hypertrophic cardiomyopathy, but does occur. And then there's another one called desmin that's not a pure sarcomeric protein, but it attaches to the sarcomere. But this gene tends to cause more of a systemic disease where you have heart muscle as well as skeletal muscle disease. So cardiac myopathy and skeletal myopathy, and they also have a rhythm-related problem, so-called conduction system disease. So that tends to be what we see, restrictive cardiomyopathy in younger people. In older individuals, they can have amyloidosis associated with it, but we don't see that in pediatric patients ever. So restrictive means relaxes poorly or stiff, heart muscle disease, cardiomyopathy. This is the rarest form of heart muscle disease. Only about less than 5% of all of the heart muscle disease patients. So again, hypertrophic and dilated take up about 70%. Non-compaction and arrhythmogenic take up the next 15% or so, and then restrictive, the remaining 5%. So this is a diastolic dysfunction problem, and it presents basically with everything looking normal, except the top chambers, the atria, are very big. Typically, the left atrium in particular is the atria, the chamber that dilates first and most. The function of the ventricle tends to be normal. The wall thicknesses tend to be normal. You may or may not have a little bit of an effusion around the heart. And at increased heart rate, these patients commonly get chest pain. And it's really the same kind of chest pain we adults get when our coronary arteries are being clogged off. We call that ischemia when that happens. So when you get anginal chest pain, it's because the heart muscle is not getting enough blood, not getting enough oxygen into it. And these patients, when their heart rates go up, get that not because they have blockage of their coronary arteries, but because their coronary arteries cannot deliver enough blood to it because of the restrictive physiology. They can get arrhythmias, which is a bad thing to occur in these individuals because the heart is so stiff it has trouble responding to any therapies. Their top chamber is a problem. It gets dilated not because it has extra blood in it, but because it has a high pressure in it. Instead of being a water balloon, it's just a balloon that's overblown, and so that's the problem. This is what it looks like coming up. It's taking its time switching to the next slide. Here it is. And so in the left panel, you can see the normal. In the right panel, the restrictive. Notice the top chambers here, very big in comparison to the bottom chambers. They're at least the same size or bigger than the ventricles, whereas you can see on the left panel, normal, the ventricles are much longer, much bigger than the top chambers. So when you see this, we call these Mickey Mouse ears. This is the sine qua non of restrictive cardiomyopathy. So the problem here is sudden death. It's this is really the most common cardiomyopathy to have sudden death, more than hypertrophic cardiomyopathy percentage-wise, but a number of patients is less because it's such a rare form of cardiomyopathy. But in pediatric patients, you could see that 2-year survival, 50%, 5-year survival, 25%, if undiagnosed and untreated. And so this becomes a problem if attention is not paid to it. These numbers are much better these days because people have become increasingly educated how to take care of this. And these are the associated problems. Particularly, they could elevate their lung blood pressures, pulmonary hypertension, which becomes a real problem for future therapies. Here's the problem. You can see on the left top panel, this is on the EKG. This is features of ischemia. These drop below the baseline, these ST segment depression here. And you can see this very fast run of tachycardia we call ventricular tachycardia, ventricular fibrillation, or they can get very, very slow, which we call AV block. And these are the modes of syncope and sudden death in this patient population, which, again, we can take care of these patients in advance if we know they have this problem, by keeping their heart rate slow and keeping, if they have rhythm risk, then they get an ICD sooner than the HCM patients would get. So these things can all be addressed. So hypertrophic cardiomyopathy is really known as the major cause of sudden death. It has more in the total numbers, but not in the percentages. So highest percentage of patients with sudden death would be restrictive cardiomyopathy, followed by hypertrophic cardiomyopathy with restrictive physiology, followed by just hypertrophic cardiomyopathy with or without obstruction. So that's the approach, that's the predictions that one would give you depending on your basic diagnosis. So that's hypertrophic and restrictive cardiomyopathy. We've run out of time to go into the next series, and potentially we could do that in another webinar and cover left ventricular non-compaction, which I'm sure a lot of people have questions about. I think that probably deserves its own hour as well. And so I'm going to stop here and be happy to take any of the questions. And I should say that if we don't cover all of the questions that come to us, we will be happy to answer them after the webinar electronically. So don't fear if your question is not answered. You will get an answer directly from me afterwards. So thanks for participating in this, and let's now go to questions. I hope this has been helpful. Thanks.
Thanks so much, Dr. Towbin. That was a great talk, very helpful, and we definitely appreciate your time. Do you mind if people also ask you questions on dilated cardiomyopathy from the first installment of the talk? Is that okay?
Of course.
Okay.
Of course, happy to.
Thank you. So go ahead, if anyone has questions, go ahead and type them in. There's one to start. As far as myectomy, is there any sort of age recommendation threshold? Is myectomy appropriate for all ages, including infants, or is there a certain age that is recommended to have that?
Good question. So there really is not an age restriction. It's really up to the comfort of the surgeon. It is uncommonly used in very young kids, but it has been done. It has been done successfully. You certainly want to have it done by a surgeon with experience doing it. It sounds like a simple surgery, but it's not. And the patients are high-risk patients. So you want it in the hands of people with experience that are very comfortable with doing it in the patient sitting in front of them. So no real age restriction, but myectomy should be reserved for individuals with substantial obstruction, number one, and this is important, and symptoms, in addition to it being significantly thick. So very thick, significantly obstructed, and symptoms. Those are the three keys to then going down the path of a myectomy. Medical therapy before that.
Okay, thank you. Another question is, can you elaborate on beta blocker usage in asymptomatic pediatric patients, specifically patients who are not obstructed? Why use a beta blocker?
Right. So as I said, I use it at the time of diagnosis, and I'm a little bit of an outlier compared to others. I'm not a big believer that waiting for somebody to develop a problem in a disorder that has risk of developing a problem is necessarily the best way to take care of a patient. I would prefer to avoid a problem than wait for a problem to occur, even though that is our approach to some extent with ICDs. I would rather not get to the state of needing an ICD. I would rather not get to the state of having somebody have a life-threatening event. And so the therapy from my perspective, once you're diagnosed, by definition, you have a relaxation problem. If the child is an active child, the child is going to raise his or her heart rate. When their heart rate goes up, the filling of that small, thickened chamber becomes less and less, which supports what they are able to do less and less, and also provides them increasing opportunities to develop the ischemia that we see in restrictive cardiomyopathy, but we also see it in hypertrophic cardiomyopathy and the arrhythmias. And so the risk-benefit ratio, in my perspective, is in the benefit category by quite a lot, largely because the use of beta blockers, at least in my patients, is a very low-risk proposition. Very few patients develop any issues with taking the medicines. We don't really, particularly in the young kids, we don't see them saying that they are dizzy, lightheaded, feel bad, feel blah, or develop breathing problems and asthmatic-like features that can occur with beta blockers. Those things are incredibly uncommon in the younger kids and pretty uncommon in anybody older. A very, very, very tiny percentage of patients that I deal with don't tolerate the medicine. Now, we start low dose and work our way up. We don't just say, okay, you need a beta blocker, here's the full dose, tolerate it. We start slow and we work our way up over time. There's no hurry, but we get them started at a dose that is going to work, but is not at your maximum dose. And we titrate it up over time depending on how the patient responds. Some kids require a very low dose to slow their heart rates to where we want it to be. And others require higher doses, but we'll get there over time. So for me, that's the way to do it. Now, as I said, lots and lots of people wait and watch, and if there's no symptoms or any other issues that they see, they don't treat. But as I told you, most patients, until they have an event, most pediatric patients will never have a symptom until they have a symptom, and that's a sudden death symptom. So so that's the difference in thinking between the users, early users, and the late users.
Thank you. So this is a follow-up question to that question. To clarify, can a beta blocker prevent sudden death, and can it stop rhythm problems?
Yeah, so beta blockers are commonly used for a number of things. In the adult population, the most common reason someone would take a beta blocker would be high blood pressure, hypertension. It's an anti-hypertensive medicine. In other words, it lowers one's blood pressure. Another reason some people use beta blockers in the older patient population, whether it's an adolescent or an adult, would be as a blocker of migraines, for instance. Some people use it for that. The other reason to use it is for fast heart rates, whether it's an individual who has fast heart rates that are not life-threatening but are bothersome, like some individuals with mitral valve prolapse, for instance, or other things where they get palpitations, beta blockers are used. But it's also used as an antiarrhythmic agent. So it is a anti-arrhythmia causing medication. Now, it's not the strongest one of those, and it depends on which beta blocker you use, but it certainly has an effect on the development of arrhythmias. So it is a prevention to an extent of the arrhythmia development.
Okay, thank you so much. We have another question, and I believe this is from the first installment when we got cut off. Would you mind commenting for dilated cardiomyopathy on any developments for future research?
Yeah. So there's currently a pediatric trial that's been started over the past 6 months or so on a drug that is being used in the adult world, and you may have seen this on commercials on television. This is a drug that goes by the trade name of Entresto. Entresto is a combination therapy, in other words, two medications used together. In an adult trial, a very large trial on dilated cardiomyopathy and heart failure, so individuals with very poor squeezing, those patients compared to patients just on an ACE inhibitor like enalapril or lisinopril had a very large advantage in survival. So if you go back in time, the first major trials that made a difference in heart failure with systolic dysfunction was the development of drugs of the ACE inhibitor class, like lisinopril. Compared to patients just on digitalis, they had a huge survival improvement. In the next era, when beta blockers started to be used, like carvedilol or Coreg or metoprolol, there was a significant improvement in comparison to beta blockers, to ACE inhibitors alone, or in digitalis alone. So the combination of beta blocker ACE inhibitor was superior in outcomes compared to either ACE inhibitor alone or digitalis alone. And so that's the standard combination therapy that we've used now for the last 15 years. Entresto, in comparison to ACE inhibitors, was better. Again, had a substantial survival benefit. So in pediatrics, we rarely will move into a new drug, particularly if it's a new type of drug, without prior information. We're not going to use kids as guinea pigs to that extent at all. And so when there's a promising medication that's been demonstrated in the adult population to work, we're then much more likely to test it in kids. And so that's really where we are at this point. There's no data. There's been a handful of kids that have been enrolled in these studies. I'm a participant in that study. There are a few other pediatric centers that are involved. And we don't know if it's going to be as good in pediatrics as it has been in adults, or better, or not. But that's from a pharmacologic therapy perspective, that's the newest kid on the block, if you will, and hopefully it does give us an advantage. We won't know that for the next couple of years, though.
Okay, thank you so much. I appreciate that comment. We have a couple more questions in the queue, but in the interest of time and to do the questions justice, I think it would be better to email those to Dr. Towbin offline for some of his comments back, and then I'll email the group with his follow-up comments as well. So I wanted to, again, thank you, Dr. Towbin, for sharing your time and expertise with our group tonight. We really appreciate it. Thank you.
My pleasure. Thanks very much for everybody attending.
Thank you. And for everyone on the webinar, this will be posted on our CCF Connect online community probably by tomorrow. So feel free to look for it there if you would like to refer back to this recording. Thanks so much, everyone, and have a great night. Bye.